Hello, everyone, and welcome. I'm Dr. Matt Clark, and I'm a Senior Specialty Registrar in Diagnostic Neuropathology and the college's undergraduate and foundation lead. This role involves me leading and coordinating the college's undergraduate and foundation activities with the aim of increasing awareness of pathology specialties and also inspiring the next generation of pathologists and clinical scientists such as yourselves who are joining us tonight. I'll be handing over to our webinar hosts, Rosie and Joy, shortly, but I would just like to start by introducing the Royal College of Pathologists and giving you a bit of information and background about what the college does. So we are a professional membership organisation and have charitable status, and we have over 12,000 members who are mainly pathologists and scientists working across 17 different pathology specialties. We also have undergraduate members and foundation fellows, so do get in touch with us if you would like to find out more about these particular roles. Most of our members work in hospitals and universities in the UK, although we also have international members working and training in a wide range of countries as well. We oversee training, exams, and professional standards across the pathology specialties, so a really important role to have. And I'm delighted to welcome you to this careers webinar on paediatric and perinatal pathology. And it's my pleasure now to hand over to Joy, who will tell you a little bit more about what's going to happen this evening. Thank you.
Oh, thank you so much, Dr. Clark. So, hi everyone, I'm Joy. I'm a fifth-year medical student at Imperial College London and one of the co-presidents of Imperial Pathology Society. And Rosie? And Rosie is our chair of Manchester University's Pathology Society. And we have been supporting the college in the running of career webinar series over the last couple of years. And we're delighted that we have a great range of speakers tonight who can talk to us about a career in pediatric and perinatal pathology is like. So our speakers for tonight are Professor Marta Cohen, Dr. Clair Evans, and Dr. Rachel Rummery, and Dr. Francesca McDowell. So Professor Marta Cohen is a consultant pediatric pathologist and has been the head of department at Sheffield Children's NHS Foundation Trust since 2003. She's currently the college's vice president for learning. Dr. Clair Evans is currently a consultant pediatric and perinatal pathologist in Glasgow. She is also the associate postgraduate dean for the National Diagnostic Specialties NHS Education for Scotland and honorary clinical senior lecturer at the University of Glasgow. As well as holding a number of roles at the college, she's also the clinical lead for national recruitment into pediatric pathology ST3. Dr. Rachel Rummery is a consultant pediatric and perinatal pathologist at Leeds Teaching Hospitals NHS Trust and honorary senior lecturer at the University of Leeds. She completed specialist training in 2023 and was appointed as a consultant in February 2024. And Dr. Francesca McDowell is a histopathologist trainee who has sub-specialised in paediatric and perinatal pathology. She's currently based in Elder Hay Children's Hospital, Liverpool. So our panel will speak for a little over an hour, and that will be followed by a Q&A in which they will answer your questions. So please remember to post your questions for them in the Q&A box, and if you're directing your question to a specific speaker, please also write their name at the start of your question. Now, please welcome our first speaker of the day, Professor Marta Cohen.
Thank you very much for inviting me. So what is pediatric and perinatal pathology? It's more. It's a medical specialty which is focused on diagnosis of diseases in fetuses, infants, and children up to the age of 16. And the beauty of pediatric pathology, to me, pediatric and perinatal, is that we do everything. When you are an adult pathologist, you do usually one or two subspecialties, but when you are a pediatric pathology, pediatric and perinatal, you do everything. So we work in surgical pathology. So there is a lesion that is a biopsy or the removal of a tumor, and it will be sent to the pediatric pathologist for us to make the diagnosis. We also deal with autopsies of fetuses between 12 weeks to, although the specialty is up to 16, because the Kennedy guideline for coronal postmortems in England are up to 18, we tend to do up to 18, but at least up to 16 years of age, autopsies, maybe clinical or maybe coronial. And also we do the investigation of the placenta, And then this is very important for current pregnancy to understand what happened, why the fetus was so small, or why it was a premature, and what also the diagnosis may help with the next pregnancy of the family. So at the center of this diagnostic specialty, we have the patients and the relatives. The families are crucial because there are all young people, and obviously when we need the consent, it's not the patient, it's the parents or the carer. So we assist hospital doctors from all specialties. Although neuropathology, if it is a tumor, it will usually go to a pediatric neuropathologist in 90% of the cases. Some pediatric pathologists may do also neuropathology, but it's not the majority, it's the very minority. And we discuss the cases at a multidisciplinary meetings. It may be that the patient is in theater and they need a frozen section because they need an immediate diagnosis to say how to proceed with that surgery after. Either it is a tumor and they need to know the margin, or is most usually a Hirschsprung disease in which there are no ganglion cells in the colon, is usually a congenital condition, and they need to know where to do the resection, so they remove all the aganglionic segments. So this is some examples. Obviously, we deal with coroners, coronary postmortems, with the police, if it is a specialty, especially a forensic postmortem, and obviously we can do medical legal reports sometimes. But this is personal, is not part of the job plan. We are involved in teaching medical students, nurses, midwives. Some of us also teach the police in how to do the investigation of a coronial postmortem following what we know as Kennedy protocol. We work a lot in pediatric cancer. We are involved in research, and that maybe some people will like placenta, some people like my area, for example, is sudden infant death and gastrointestinal pathology. That are the areas that call more of my research. And bereavement. And bereavement is extremely important because, as I say, our patients are children, and therefore there is a family behind. And sometimes, especially when there is a postmortem, and I work at the Sheffield Children's Hospital, the families will come to visit their child, and sometimes the families would like to speak to the pathologist. And it's hard to have a difficult conversation with the parents, but it's also very helpful to them because it helps them start with the grieving process and having a clear explanation of what happened with the child, why the child died, etc., etc. I say from macroscopy to microscopy because we need to correlate. Sometimes it's at the autopsy, and we will examine an organ and we'll say, okay, this is a malformation, or this seems an infection, and that will guide me the samples that I will take at the postmortem. Or it may be that there is a surgical specimen, and we see an area that, oh, this is an ulcer with hemorrhage, so I'm going to sample from here. And also I may sample from the resection margins, because the surgeon needs to know if the margins are involved in the condition. We obviously work with the lab. The biomedical scientists or the mortuary technicians are part of our team, and they will process the samples. They will work very closely with us, and they will produce the sections, cut the sections under the like 4-micron sections, stain. Everything is automatic now. And the pathologist, this is me 20 years ago, we'll look at the microscope, and sometimes we need extra sections, we need deeper, or we need immunohistochemistry, or we think it's a virus, or can we do PCR and do paraffin curves to do a PCR investigation. So pediatric pathology is wonderful because it combines the knowledge on embryology, because you need to know what is normal and what is the abnormal development to go with the malformations, that is the anatomy as well. And obviously the histology. we need to know the normal, because we cannot know everything. So what I always say to my trainees and my students is, know the normal, because if it is abnormal, you will realize, oh, this is the abnormality, and then you will be guided to search what it can be the diagnosis. So we work with other fields that are in our periphery, but work very closely with that, and they are embedded in our histology of surgical specimen or autopsy. That is genetics. More and more we are depending in genetics, in whole genome sequencing, etc. We need microbiology, virology. We work with infectious diseases. We were very important during the pandemics because we made discoveries about the placenta, how the placenta got infected, and the causes of death in COVID in children. We work in solid tumors, leukemia, lymphomas, hematology. We work with immunology, rare diseases, especially conditions that are new and that day and day we are discovering or getting to know them, placental pathology and forensic. Because in England, there is this protocol, Kennedy, in which when there is a suspicious death and the postmortem is forensic, it should be a joint postmortem, a pediatric and a forensic pathology. So the two work together to see what is the natural, the pediatric pathologist, and what is the unnatural, the forensic pathology. And we work in teams as well with the obstetric team, with the ENT, pediatric, surgical specialties, endocrinology, oncology, with radiologists. We are more and more into doing a minimal invasive autopsies with postmortem MRI or CT scans. So my journey, I really came to pathology by chance, I think, because I didn't feel comfortable working with patients. And when I finished my general pathology training, I went into pediatric, and I really love the specialty. I'm glad that it went that way because I will do the same. I trained in Argentina, where I am from. Then I did my 2-year fellowship in Cape Town, South Africa. And then I went back to Argentina as a consultant. And then I came here recruited by the NHS 22 years ago. And the tips I can give you to enhance your career growth and the learning, my advice is that each of you focus on developing strong analytical and problem-solving skills. Enhance your communications abilities. It's very important to talk to colleagues, to talk to peers, to show your cases to another to see if they agree or if they can give you an advice about their opinion on a case. Cultivating your commitment to continuous learning and building a strong relationship with colleagues is extremely important to work in teams and to be part of a very good team. It is great if you have attention to details, because in histology, you have clues, or in the autopsy, you have clues that will say, oh, this may be this condition or that condition. You have to be patient. Sometimes it's very difficult to get the diagnosis and time-consuming. And you have to have the ability to work under pressure. And my tips to success are to seek mentorship. It's important to have a mentor, to embrace any learning opportunity that you have, to connect with others, to learn from errors. Don't be afraid to learn from errors. That will make you an experienced pathologist. To attend meetings. And I will tell you, my mother and my father, they were both pediatricians. And my mother, when I was starting my training, say, go to meetings, I go to dinners. Because at the dinners, people talk and you make friends. And I tell you, this is extremely important. And it's also extremely important to be resilient. So these are my tips. And this is my last slide. I thank you for your attention, and let me know any questions at the end. Thank you.
Right. That was great, Marta. And I appreciate the tips for ongoing training, and I'll explain that shortly. So my name's Clair Evans, and as I was introduced by Joy, I'm a consultant pediatric and perinatal pathologist, and I work up in Glasgow. So I'm going to do a bit of talk about my pediatric pathology journey, and then I'm going to give some information about the role of the college in pediatric and perinatal pathology and a bit about training as well. Next slide, please. So don't judge me for some of these. My personal journey through pathology. I suppose this is a personal and professional way I got into pathology. And if we start on the left-hand side, we've got Sir Keith Simpson, who was a forensic pathologist who used to work in London. Now, this is well before my time, and in fact, I think he probably died some while before I was born. But one of my elder relatives at home worked in London in the police force and had seen postmortems with Keith Simpson. So it had stuck very much in my relative's mind about watching the postmortems and describing, not in detail, but the kind of awe that my relative had for watching him work and how he came to a diagnosis and was able to answer questions as to why somebody died. So that was one thing in the background that it was spoken about at home. None of my relatives were medics. And then, of course, if you look at the bottom, TV shows, and don't judge me on this either. The picture there for those of you who are probably not old enough to recognize this person, but this is Quincy. So there was a TV show in America many moons ago, and they used to run reruns of this, and he was a medical examiner, so basically a pathologist, and then he'd go out and solve crimes. So that was another kind of thought as well. I really quite like pathology. I can't say I was ever into silent witness or anything like that, but these kind of things were playing in the background, and that was even before I got to medical school. Then moving further right, there's a couple of pictures there. So Professor Paola Demizio was one of our pathology tutors at Barts in the London. And I think she was a great role model for people. She was always larger than life, had these really bright, garish jumpers, and really inspired a lot of people to, concentrate and study hard on pathology. Although I do remember that our third year at college, we were told off for being the worst year she had ever known. But that didn't dampen my spirits for pathology. And as part of that kind of undergraduate learning, and these books have been, have had many editions, but there's things like Wheater's Functional Histology, Underwood's Pathology, and other textbooks are available. But those kind of things really interested me and fascinated me. And one of the things, it's like Marta's saying, the kind of quality, the curiosity of what drives you forward, but also using your personal positive attributes to drive you in your career. So if you're really good at visual recognition, multitasking, and being able to problem solve, be prepared to learn from your mistakes, then pathology is definitely something for you. So after medical school, obviously do my first few years as a junior doctor, and then I started training in pathology in Sheffield. And initially, my first placement was with Kim Savannah over at the Northern General Hospital in Sheffield. And let's just say he was a force to reckon with at times, but he was an extremely good educator. And I definitely learned, my basic autopsy skills from him. And also how to be quite careful in how you word reports when you're examining specimens under the microscope, how to trim them, how to examine them, and the beginnings of how, like Marta says, being able to come to a diagnosis from all the clues that you might see when you're looking at the histology. James Underwood, who has been president of the Royal College of Pathologists, he was also a Sheffield-based consultant. And thanks to him, every time I look at a duodenal biopsy, I will always check that there's no giardia. So there's always something that you can learn from somebody, but he was an extremely professional person. He was a good communicator. He was very personable, and he was a very patient educator as well. And after I'd done a little bit of time in the adult pathology, I then come across, of course, Marta at the Sheffield Children's Hospital. And at that point, with Marta's kind of enthusiasm, I then decide that I'm going to go into paediatric pathology. And partly, as Marta has said, paediatric pathology, you have the opportunity to do a bit of everything. You're not sitting with one organ system. You're not a specialist necessarily of one organ system. You're getting to see specimens from everything, a whole range of different pathologies, whether that be tumor-based or non-tumor-based, autopsy pathology, placental pathology. There's all sorts of things, and there's always new things to learn. That never stops. So that's my professional and personal journey into paediatric pathology. And I'm now up in Glasgow. So next slide, please. Okay, so thank you. So my next topic, moving on from my own personal journey, is really to highlight a bit more about what the RC Path role is in paediatric pathology. And the college has lots of roles, and Matt obviously outlined many of them at the beginning of this webinar. But specifically for paediatric pathology, what we're involved with is assisting with postgraduate medical training and, of course, the undergraduate engagement that the college does. But particularly with regard to specialist training, the college is the one that publishes or produces the training curriculum and syllabus framework for training in the specialty, so that it gets revised every so often. Once the college has drawn it together, published it, and it's been approved by the General Medical Council, it then becomes a recognised training curriculum for people training in the UK in the specialist medical training framework. We spend lots of time or the college spends lots of time supporting the documentation and the process of postgraduate training in paediatric pathology. So there's a big training team who are involved in all the workplace-based assessments and portfolios involved with trainees. We run the Part 2 paediatric pathology examination, and as a part of an explanation of that, every pathology specialty has its own fellowship examinations. And for the training pathway for paediatric pathology, a resident trainee would expect to start in general histopathology for a couple of years and do the Part 1 histopathology exam. And then once they move across into paediatric and perinatal pathology, after a period of time, we'll then do the Part 2 paediatric pathology examination. And that exam is done quite late on in training, so it's almost an exit exam prior to consultant work. We also produce a lot of guidance for practice in paediatric and perinatal pathology. So if you have a look on the college websites, there are lots of publications related to how to handle certain specimens, practice guidelines, so tissue pathways. We have one of those for the examination of the placenta, data sets for looking at particular tumor types. So, we've got kidney tumors in children, neuroblastic tumors in children. And then we've got guidance on autopsy practice for perinatal cases, and we'll have others coming out shortly for the sudden infant death cases. So lots of guidance to try and keep a kind of uniformity of practice across and to keep the standards up, because by using these data sets and tissue pathways, they're easy to be audited and reviewed and updated as practice requires and as knowledge increases. We also work very closely with healthcare providers, the statutory training bodies, which are the deaneries, other royal colleges and charities. So there's quite a big remit for us. Next slide, please. So training in paediatric pathology. I've mentioned about the Part 1 exam. Essentially, the current training pathway for specialist training leading to the CCT certification route would require that you would start training in general histopathology, complete your first 2 years and the part 1 histopathology exam, and then you would apply for an ST3 post in pediatric and perinatal pathology. It's separated because the curricula are separated and they are regarded as separate specialties. So currently there isn't a kind of seamless run through from one to the other. You do have to apply for the ST3 recruitment, but that's done centrally and is not a particularly arduous process. The training pathway for pediatric and perinatal pathology typically is 3 years. And as I said, the part 2 examination is taken quite late on in that training. So you'll probably be an ST4, even an ST5 by the time you're taking the part 2 examination. Some people be obviously curious as to where the current training sites are for pediatric and perinatal pathology. And we have sites all over the UK. So on the list here, we've got London, Cambridge, Oxford, Manchester, Liverpool, Sheffield, Leeds, Southampton, Newcastle, Cardiff, Glasgow, Edinburgh, and Aberdeen. So there's quite a wide range of centres where training is possible. And we have a national training programme director for England, and that's Professor Liz Hook. And she oversees the programmes in England and is constantly seeking to expand the training capacity and the number of sites that can take trainees for paediatric pathology. So I'm going to stop there so to allow the other speakers to continue, and I'm very happy to answer your questions at the end.
As was kindly mentioned in the introduction, I am Rachel Rummery. I'm a consultant paediatric and perinatal pathologist in Leeds. And I've been asked to give a personal reflection on my career and also the transition from resident to consultant for those of you perhaps who are slightly later on in your career, or alternatively, as I will say, perhaps consider the relevance to your life going forward. So my training pathway, which has been briefly alluded to in the introduction, is actually relatively unusual. And I started having my very first pathology career in the 1990s. Funnily enough, also read the forensic pathology books of the people that Claire was mentioning. I did medical school at St Andrews University and then went on to Trinity College in Cambridge, where I became one of the very first Kalman registrars and a lecturer in histopathology in Nottingham. However, I then had a very long career break at home with my children and returned to medicine in 2011. Not an easy process. I had to redo my foundation competencies. But I did succeed in that and re-entered histopathology training as an ST1 in 2013. I then moved into pediatric and perinatal pathology via the process Claire described in 2016 and was appointed as a consultant in February 2024. So during my training, I had the opportunity to be involved in numerous extracurricular activities. I was fortunate enough to be one of the Health Education England, as it was at the time, inaugural National Support Fellows for returning to training, and then became the clinical lead for return to practice. This involved a lot of work with the GMC on international medical graduates, welcome to UK practice, a large survey on why doctors leave medicine, what might help them come back, and also on EDI issues. I also had the pleasure to work with Matt, who is chairing tonight, as Vice Chair of the RCPath Trainee Advisory Committee, because we were trainees then, not residents, and the Academy of Medical Royal College's Trainee Doctors Group, which again was a real opportunity to see the inner workings of the NHS and medical education at the very top. However, I also had some issues. I think it's fair to say I really struggled with my Part 2 exit exam, and I struggled in a very specific way, which led to me being diagnosed autistic with ADHD and dyspraxia. And indeed now I am currently the pathology lead for Autistic Doctors International, and I sit on the NHSEI Neurodiversity Task and Finish group. Why does this matter? What does my career show or highlight? I suppose pediatric and perinatal pathology is a small specialty. There are only in the region of 50 consultants, in the region of I think 12, 13 resident doctors now. And this really allows personalisation. It's a very welcoming and inclusive specialty. I obviously, when I wanted to return to medicine, thought my career break and my age would really count against me. But one of the very first people I contacted when I wanted to return was the local training programme director actually in Nottingham, who encouraged me that histopathology was a really broad church where everyone was welcomed. And I have to say that has remained true through histopathology and paediatric and perinatal pathology. As I think I've demonstrated, extracurricular opportunities are really encouraged. Mine were more managerial and leadership, but research, for example, again, the opportunities are really there. The size also, I think, allows a degree of support, which is potentially unusual. I had a lot of support around my exam, both individual and from the wider specialty. So the transition to consultant might seem quite a long way to some of you, maybe less so to others. And when I was thinking about this, because I haven't been a consultant that long, it's only been about 1.5 years, and I'm certainly not there yet, I thought of what you're trying to be. And I suppose the aim is to have clinical competence and confidence, good interpersonal skills and team working, and leadership and managerial capability. There are others, but I was hoping that encompassed most of it. How you get there, and as you say, I'm still a work in progress for me, is very individual. And it's often thought of as a relatively defined process, which starts later in training. However, my personal experience of the transition is actually it's a pretty holistic and iterative process which encompasses all of life's experiences. I don't really think any of them, good or bad, are wasted in becoming a good, kind, calm, competent consultant. Some of the things I think are helpful are learning to accept being good enough. Not that easy for medics always, but the adage that perfect is the enemy of good can really be true. If you learn to be good enough, it's easier to be calm and confident. If you know your weaknesses, you can have more realistic expectations of yourself. If you accept your strengths, you can also aim to make opportunity to use them. So how do you get there? What might help you get to that point? Again, still a work in progress. But the things I've found is that embracing personal insight and self-reflection in training is really helpful. It's mentioned a lot, and I'm not sure it's always valued as much as it should be. Because actually in training, you do get a chance to have the time to think about these things. What are your weaknesses? What are your strengths? How are you going to improve your weaknesses and build your strengths? So I think that not hiding your weaknesses is really important. And when you become a consultant, it makes you much less brittle. Because if you've addressed them during training, and I don't mean you can necessarily change them, but if you've improved the ones you can, and accepted the ones you can't change, it is easier to be kind to yourself and remain, I say, essentially happy and balanced. The flip side is really take opportunities to build your strengths and to challenge yourself. So I'm not suggesting for one moment you should just accept your weaknesses and not try. Flip side is whatever you're good at, see if you can really bank that too. Be realistic about your ideal consultant post. Try and choose somewhere with a location and a work-life balance that suits you, a type of workload that actually you would like. Some people prefer more surgical work, some people prefer more post-mortem work. Do you want to do research? Do you not? Choose a post that really reflects that. And again, the chances of being happier are much greater. But above all, I have to say, to transition to consultant happily and well, choose your colleagues wisely, because they will be your greatest support and make it much, much easier. And they are your long-term career colleagues. So thank you very much. I hope that was helpful. And I will now stop sharing and hand back to our next speaker.
Thank you, Rachel. Your talk really resonated with me as I start to enter the end game of my training. But I would like to share with everyone today just an overview of what it's like to be someone like me, a senior registrar in paediatric and perinatal pathology. So if you bear with me, I will try and share my screen. Okay, no one's saying it's dreadful, so
Yes, it looks good.
I'll get going. So just introductions. I'm Francesca. I'm an ST5 in paediatric and perinatal pathology, and I'm based at the beautiful Alder Hey Children's Hospital. So my talk is essentially, I'll just give you a very brief overview of my journey into paediatric pathology, and just to describe a typical day in the department. And the picture to the right is just a picture of our hospital on a beautiful sunny day, and it was probably like that today as well, although it was too hot to go outside. So my journey to paediatric pathology. So went to medical school. I'm a medical doctor. So I graduated from the University of Oxford in 2018. And during those 6 years, I also got an intercalated Bachelor of Arts in Infection and Immunity, at which point I was introduced to the wonders of the placenta and its complex immunology. Then went over to Stockport in Greater Manchester for F1 and F2 between 2018 and 2020. I was very lucky enough to have a foundation job that had a histopathology placement in it, intermixed with sexual health and occupational medicine. It was a very odd block, but it was a great opportunity to get some exposure to histopathology as a medically qualified individual. And immediately in 2020, that glorious year, I entered histopathology training in Mersey, based at the Royal Liverpool Hospital and its surrounding district general hospitals, where I completed ST1 through to ST 2.5. So I did a little bit of ST3, and then as soon as I physically could, I got into paediatric and perinatal pathology. And again, I managed to get my dream placement in Mersey Deanery at Alder Hey Hospital, where I am to this day. So I've nearly completed my training. I'm the last few months of my training, so I could give you a good overview of what it's like. So why did I go for Peds Path? So I think one of the joys of going to a more traditional medical school is that I have quite a strong science background. I think that kind of naturally led to a curiosity in pathology in general. I spent way too much time in the gross labs and the histology workshops. So I was naturally attracted to the specialty. And the joy of paediatric pathology is it is so holistic. It is so multidisciplinary. There's not a day that goes by I don't interact with a clinician, be it a paediatrician or the other branches of pathology, microbiology. I work with very closely with both surgical and autopsies. So it is paediatric pathology is a really way to kind of really work with other branches of medicine. And again, paediatric pathology, variety is the spice of life, and there is so much variety in Peds Path, and you can tailor it to do as much surgical as you want or as little, and it's just such a great mix of things, and it can be tailored. And I think that's the joy of paediatric pathology to me. But let's move on. What's my day like? So every department is slightly different. So this is my personal experience. So 1 to 2 days a week, I'll be on surgical. So that is our biopsies, our resections, and our placentas. And then 1 to 2 days a week, I'll be doing my autopsies. And then 1 day a week, and I'm only 1 day, I'll be off rota to allow me to catch up with admin work, my reports, readings, personal development, portfolio, whatever it is. And it's 9 till 5, and there are no weekends, which is definitely a bonus. So I'll describe a typical surgical day for you. So a typical Monday will involve reporting of the biopsies that had come to the department on the Friday and have been processed over the weekend. They usually come out about 11, 12 o'clock, depends how many really. And on a Monday, we also have our oncology MDT, which is where we have our surgeons, our oncologists, pathologists, radiologists, and we all come together to talk about our children who have diagnoses of cancer. So this would be the solid tumour MDT rather than the haematology MDT. On a surgical day, I'll be expected to do the cut-up. So that would be dissecting any specimens that have come in from the operating theatres, and placentas would also be cut up at some point during that day. And then there's also the handling of fresh tissue. So if a child has a tumour, it will more likely than not be received to us during the day as a fresh sample, so not in our fixative solution, formalin. And we have to handle that appropriately to store some of the tumour for frozen storage so that it can be used for genetic analysis in the future, which might help guide treatment. And other examples of fresh tissue would include our rectal biopsies for the diagnosis of Hirschsprung's disease, which is when the nervous system of the bowel doesn't develop properly. So they all need to be handled fresh for various reasons, which I shan't whittle on about because I'm aware of time. And also, there is plenty of time to do reading and portfolio work. You are a trainee. You need to. It doesn't come naturally. One has to read and reflect on your work. So there's plenty of time to do that as well. It's just a little picture of my desk. So you can see my microscope, my digital screen, because we are slowly working towards in Liverpool digitalizing our service. And a little shout out to my plushy uterus and my plushy Hirschsprung's colon that are just in the foreground there. They are my treasures. So we'll move on to autopsy. So an average day, I may have 1 to 3 autopsies to do when I'm rotated to do autopsies. The way it works at Alder Hey is that you have quite intensive training for the first few months. So I didn't do anything but autopsies for maybe 2 to 3 months. And that fully supervised, had my hand held the whole way. And then after that, I was largely independent doing my autopsies. But it's really important. There's always somebody available to ask if you're just not sure. Oh, is this particular cardiac anomaly? Should I do this? Should I take microbiology? There's always somebody available to help, so you're not just left on your own to crack on. If in doubt, chicken out is one of my mottos when it's with that. On an autopsy day, we may have our fetal dysmorphology MDT, which is when we discuss cases where the child or the fetus has got some form of anomaly, and that's discussed with our genetics colleagues, whether or not further genetic testing is indicated, and that just allows our service to be streamlined to allow parents access to genetic testing to help plan for future pregnancies and their recurrence risk. So that's a really good meeting to go to. And of course, autopsies need to be written up, and there's admin with that, so I need to do that. And again, there's usually time for reading and portfolio work to continue your professional development. Just a few pictures here. So this is our gross lab table. So this is where I would normally do the perinatal autopsy. So those would be our fetuses from 12 gestational weeks all the way through to term. Anything larger, we have a larger table. And if they're particularly tiny, or if there's something you really just can't get a grasp of with the naked eye, we also have our dissecting microscope, which also has a screen, which we can use to take photos or show observers any pertinent findings. And I just wanted to share with you some pictures of our bereavement suite. So this is a calm, quiet place where parents can be with their children. So this is a refrigerated cot. So it's just really the autopsy is obviously one side of things, but obviously bereavement care and support is also there, and that we work closely with our bereavement colleagues to ensure that babies are handled appropriately and are treated with the utmost respect at all times. And so my final slide is just a summary of I could go on forever about the pros of paediatric pathology, but I wanted to keep things balanced. So I'll start with the pros. Pathology in general, but especially paediatric pathology, in my opinion, you will have a lifetime of learning. Paediatric pathology moves at a pace of, like a whirlwind. We are very much at the forefront when it comes to molecular pathology, particularly in the world of paediatric oncology. It is a holistic specialty, as I've mentioned before. There's a good mix of different elements of pathology coming together to make one unifying diagnosis. We are not an island. We work with immunology, we work with metabolic, we work with microbiology. We are truly holistic. And we're also, I like to describe paediatric pathology as the only branch of pathology where you are a specialist generalist. So we do everything, but in our very niche little area. And I find that quite exciting. It is a small and friendly community. I can say I've spoken to the vast majority of trainees and consultants in the country. That's quite a nice sense of community there. There is the lifestyle element as well, with histopathology being pretty much working hours. The specialty is highly amenable to less than full-time working. I'm a less than full-time trainee myself, and particularly as digital progresses and when you can become a consultant, there is definitely more scope for flexible working. But there are cons. Nowhere's perfect. So training places and consultant posts, as Claire has mentioned, they are limited to the major cities. So if you wanted to live in a croft in the Highlands, it's going to be a bit tricky for you. As we're only small, you may actually be the only trainee in the department. So I'm on my own at the moment, but we are getting a new reg. So it's like me getting a little brother or a sister. So some people find that a put off, but some paediatric trainees work alongside the general trainees as well. There is a lack of patient contact on a daily basis, so that is something to consider. And exams, they're a thing, but it's not unique to histopathology, and I felt very, very supported during my recent exams, and I passed. So it's not a unique thing, but I would say all the support from my consultant colleagues and resources that have been provided by the Royal College of Pathologists will stand you in good stead. But that's all I've really got to say. I'm happy to take any questions if there are any, and I'll just try and unshare my screen. Thank you.
Thank you very much, everybody. We're just going to hand over to Joy and Rosie now, who are going to lead a Q&A session. So please, if you've got any questions, please do pop them into the Q&A box at the bottom, and we'll field them to the speakers.
So thank you so much for the talk. It was it was amazing. And we have one question in the Q&A chat right now, which is, I'm an IMG and have passed my FRC Path Part 2 examination. What will be my route to enter into this?
At the moment, there are two possible pathways into paediatric pathology. I've outlined the one which is via ST3 training and through the CCT route. Now, if you've already got your histopathology Part 2 examination, you might want to keep an eye out for potential fellowship posts being advertised in centres, which would be 2 years basically, and then building a portfolio. And you can apply, if you want to, via the CSER route onto the specialist register. And depending on your level of previous experience, you'd be able to make a choice on whether you apply as a histopathology CSER or paediatric and perinatal pathology CSER. So there are options available to you. If you want to apply for the ST3 post, that's absolutely fine. You would probably find that the training pathway would point you in the direction of doing the Part 2 paediatric exam, but there are options available. So I think Marta has got her hand up because she's been involved in the fellowship program.
Thank you, Claire. Yes. And actually, we have been interviewing international medical graduates who have passed Part 1 and Part 2. And the last round one had enough experience. So to go through the fellowship route that is between 18 up to 24 months is required experience in pediatric pathology in the country of origin. And when we didn't sense that, the route then is ST3. So that is, we can help you, and maybe if you need to contact me outside of this, happy to help.
Great, thank you so much. And we have another question from Dewey Doan. Could you please let me know the types of specimen you encounter in your daily practice? Do you sign out lymph nodes and muscle pathology?
Yes, I mean, I can start with this, but as we all say, because I think we all say, the same, that is, we agreed. It will depend the hospital you are, because you may be in a hospital, for example, in Sheffield. We are merged with the adult hospital, so we will do the initial reporting of the hematopathology, the lymph node, and we will discuss and present the case at the oncology meeting, but then it will be going to HOT, that is the adult hematopathology team that is giving like the second opinion, and is part of this being part of the new system. In the past, we didn't need to send it to the adult hematopathology team, but muscle biopsies, we will report them as well. But I think it's also depending on what do you want to do. Some people may want to do more autopsies. Some people may want to do more surgical. So it's a balance.
Great. And I think Dr. Clair Evans has her hand raised.
Yeah, as Marta said, there is variation depending on the department. There's also variation depending on which part of the UK you work in as well. So central review of certain tumour types occurs in different parts of the UK. So it doesn't always happen in our department, for example. But yeah, there's a wide range of things, and we get a lot of hematopathology in our department, but our neuropathologist reports the muscle biopsy. So it just depends where you work.
Great.
Thank you very much, everyone. I'm going to have to jump in now to bring the webinar to a close. Apologies, Leah. We'll get back to you outside of the webinar with an answer to your question as well. But thank you very much to all of our speakers, to Rosie and Joy, and to all of you for your questions as well. I think you'll agree they were a fantastic set of talks, and hopefully you're feeling informed more about this specialty now. We will send you a short feedback survey by email, so please share your thoughts about the event via that. You can also watch previous careers webinars on our YouTube channel as well, so do take a look at this. And we will also add the recording of this event to the playlist as well. Do keep an eye out on our social media channels, particularly Instagram, for details of future career events. And we hope to be running a careers webinar in forensic pathology in the autumn, so do look out for that. Also, the college's Science Communication Prize is currently open to undergraduates, foundation doctors and trainees, and you can find more information about it on our website or by scanning the QR code that's on the screen at the moment as well. And finally, you can find out more about pathology on our website, YouTube channel, and via Instagram as well. But just finally, thank you so much to all of our speakers for their fantastic talks tonight, and thank you all very much for joining the webinar, and hope to see you again soon. Thank you very much.
Thank you.